Good morning, everyone. Thank you for turning up to my talk. That's on amniotic fluid embolism. I think the topic has been covered in these sort of meetings in years before, as Alan mentioned, but hopefully we will get a bit of a further update and refresher. So I'm talking about a case study that happened in Theatre 1 in Westmead. Sanjay and Jane actually did the case, but unfortunately they couldn't make it today to the meeting. It's a 35-year-old Mrs. AR who was a G2P1 and had a previous normal vaginal delivery in 1998, 38 weeks, and presented with PV bleeding with a diagnosis of grade 4 placenta previa. She was booked for a Caesar, and the patient preference was for it to be done under general anaesthetic. So the patient had a routine induction and was hemodynamically stable for the beginning part of the surgery. There was estimated blood loss of about 2 litres, hemoglobin dropped to 70 and was given 1 PAC cells, syntocinon, syntometrin and prostaglandin F2 alpha. About 90 minutes post-delivery, patient was kept breathing spontaneously on the tube, waiting to do tap blocks when there was a sudden loss of end-tidal CO2 accompanied by a drop of saturation to 60%. Patient was cyanosed, shut down and had very faint pulses. So what would you, if you imagine yourself in that situation, what would be your differential diagnosis going through your mind, Jeremy?
Very hard to think clearly when we know what the topic is, but...
No, differentials.
Yeah. So it's not a amniotic fluid embolism, it could be a pulmonary embolism. It could be anemia or other cause of
So we've got a patient who's extremely hypotensive, hypoxic, and okay. I'm sorry? No, but that's a good question. So it could be local anaesthetic toxicity from tap block. That's good. So how would you manage this? What would you be doing? What's the immediate things that will run through your mind?
Stop doing a tap block and verify the airway breathing and circulation, and I would consider starting CPR on the basis of no cardiac output while I was organising other interventions like adrenaline fluid volume expansion, 100% oxygen, and call for help, yes indeed.
That's right. Very important. Call for help. That's correct. So for guys who walked in late, we've got a 35-year-old who's having a caesarean section for PV bleeding, secondary grade 4 placenta previa. We're doing a general anaesthetic as patient requested, and basically 90 minutes post-delivery we get a sudden loss of end-tidal CO2 accompanied by a drop of saturation, and we've just gone through differential diagnosis and how, if you were in that situation, how you would manage it. So basically, that's what Sanjay and Jane did, hit the emergency buzzer, ventilated the patient 100% oxygen, listened to the chest, there was slight wheeze bilaterally, they started IV resuscitation, gave some adrenaline, about 2 lots of 100 micrograms, and the BP responded well to this, and there was no rash. So Sam... Yeah.
She actually lost 2 litres of blood.
This was before she actually, that's right. So during the case, until the delivery. I'm sorry?
She's just under-resuscitated big time.
Under-resuscitated? Well, up to that stage, she's had 2 litres of crystalloid and 1 PAC cell, and the hemoglobin was 80 and she was hemodynamically stable. There was good urine output, so the thought was that she was well resuscitated, and it wasn't a bleeding issue from.
Get a sudden drop in end-tidal CO2 unless you have a disconnection. It's really suggestive of
something acutely.
Which is some kind of embolus, whether it's thrombo, amniotic, air, it doesn't matter. It's
That's right. For
But
a
to get
The point cardiac collapse or like
Correct.
So Sam, what further investigations do you think we could do at this stage? So we've stabilised the patient, and we have time and a second pair of hands to do some investigations to help our diagnosis. Mm-hmm. So we can send some bloods off, tryptase, as well as what other investigations would you want to send? An echo will help. So you've got a patient who's hypotensive, there's sudden occurrence of hypotension. Would an echo help?
Yes.
So, Adam, could you tell me, without cheating and reading the bottom, what can you see in this echo?
This is actually, this looks more like a toe transthoracic, so we can see ventricles at the bottom of the window rather than the top. So this is like a transesophageal chamber. You see the left ventricle on the right-hand side of the screen, the right ventricle on the left-hand side of the screen. And the thick stripe down the middle is the interventricular septum. And you can see that that's tending to lie more towards the muscular left ventricle than towards the right ventricle, which would otherwise be the case. So this suggests that overload pressure over the right ventricle.
And in fact, that's what they found. So they did a transthoracic first, which showed a dilated right ventricle with strain, but an empty left ventricle. And then by the time they actually got the toe and did a toe in 15 minutes, that was gone. It was sort of looking more normalish. So about 20 minutes following this event, the patient was noticed to be extremely oozy from the wound and having continuous PV blood loss. The pathology that we sent, Sam, came back as severe coagulopathy with an INR of 1.8, APTT of 90, low fibrinogen, high D-dimers, platelets were 38. So basically the patient's now going into DIC. She was further and continued to lose blood and had to overall be resuscitated with 16 units of PAC cells, about 10 litres of crystalloid, 6 FFBs, 2 pooled platelets, 8 cryo and 2 prothrombinects. She was also given factor 7 and amniocaproic acid, and despite that she needed to proceed to have a hysterectomy. Fortunately, she remained stable during the hysterectomy and was sent to ICU post-op. That she remained ventilated for 2 days and discharged from hospital in 6 days. So without any prolonged sequelae, she was a very lucky patient. So we're going to now talk a little bit about amniotic fluid embolism. It's basically thought to occur when the amniotic fluid and fetal cells and hair and debris all enter the maternal circulation. Passage of amniotic fluid into maternal circulation was first described by Meyer in 1926, but the actual syndrome was described by pathologists Steiner and Lushper in 1941 when they did a series of post-mortems and found all these women who died during labour with these amniotic debris in their post-mortem in their lungs. But it was not listed as a distinct heading in cause of maternal mortality until 1957 when it was labelled as obstetric shock. It's estimated to occur between 1 in 8,000 and 1 in 80,000 deliveries. Mortalities are extremely high, about 60%, despite aggressive and immediate treatment. And unfortunately, there's quite high morbidity associated with it as well. About only 15% survive neurologically intact from the extreme hypoxia that they get during the event. Now there has been some associated risk factors, although it doesn't necessarily mean anything. Just in the big case studies and in the data collection that they've got from the registries, they've found that there is some association and higher risk associated with multiparity, advanced maternal age of over 35, having a male fetus, being atopic, which these two might indicate there's some immunological aspects of it, associated with trauma, preeclampsia, and operative deliveries, basically. Time of event, it's been noted to occur during labour, during caesarean section, and after normal vaginal delivery, or even during a second trimester termination of pregnancy. In the descriptions previously was within 30 minutes of delivery was a part of the description, but they've got rid of that because, as you could see in this case, there have been more and more cases of delayed presentation of amniotic fluid embolism. The classic presentation of the syndrome has been noted with acute hypertension and cardiac arrest, acute hypoxia, and then further on coagulopathy and severe hemorrhage, but it has to be in the absence of any other explanation, so it's a diagnosis of exclusion. Basically, you should not have any other causes to account for this presentation. And there are further signs and symptoms with frequencies of them that could be associated with the syndrome. As you can see, most of them would become hypotensive with some degree of respiratory distress and coagulopathy, which are the main three features. Some women have been noted to present before the massive syndrome with minor signs and symptoms like restlessness, agitation, numbness and tingling. I mean, how many patients have you had during a caesarean that complained of these minor things to you? But it's something to be aware of that in the case studies that they've had, some of them have had these premonitory symptoms before actually deteriorating and collapsing. And also unexplained fetal death is a feature that's been noted in 20% of the cases that could precede maternal deterioration. So it'd be worthwhile in someone who's had a sudden loss of fetus without any particular cause to monitor the mum for 24 hours with pulse oximetry in case they deteriorate, for it to be noticed earlier. So that's a recommendation that's come out of this. So yes, as you said, differential diagnosis, it could be obstetric causes like acute hemorrhage, placental abruption, uterine rupture. As you said, Alan, with the sudden loss of output, it could be anything like uterine rupture, abruption, that you lose a massive amount of blood as well as part of your differential diagnosis. But some people present with fits, so eclampsia, and also anaesthetic causes, the high spinal aspiration, local anaesthetic toxicity, and pulmonary or air embolism, anaphylaxis, magnesium toxicity, septic shock, transfusion reaction. I mean, our patient had quite a few things, had a transfusion, had prostaglandin F2 alpha, but it was quite delayed and sudden 90 minutes after all these events. So pathophysiology of pulmonary amniotic fluid embolism is poorly understood. It was first characterized by the presence of amniotic fluid debris in maternal pulmonary circulation, and the amniotic fluid was thought to be the cause of this embolic phenomenon. But then Lee et al. Demonstrated that fetal squamous cells can be found in pulmonary circulation of women without these syndrome. And then we've done a lot of experimental studies that produce mixed results, and even injecting the amniotic fluid into the circulation have only been able to produce this syndrome only in some cases, and some of them have only been successful doing that when it's been stained with meconium. Now, Clark et al. Recognised that the clinical course and hemodynamic changes of amniotic fluid embolism were similar to patients having anaphylactic shock, and proposed that amniotic fluid embolism could be more an immunological reaction rather than an embolic phenomenon, and basically suggested that it can get minor effect from mechanical obstruction from the hair and the vernix and the squames, but then the major effects comes from the biochemical mediators like the thromboxane and prostaglandins and all those vasoactive mediators that cause the pulmonary vasospasm, and suggested to call this syndrome anaphylactoid syndrome of pregnancy. And he suggested a biphasic model that basically amniotic fluid and fetal cells enter the maternal circulation, and these mediators cause severe pulmonary vasospasm and pulmonary hypertension with elevated right ventricular pressure and right heart failure that would produce hypoxia. So most people would die within the first hours because of that hypoxia. They never get over that severe vasospasm and right heart failure. But then if they survive that, they could get to myocardial damage from that hypoxia that's postulated, or directly from the vasoactive material that's been released into the circulation, then get left heart failure. So people who survive then further down the track, they get left heart failure and pulmonary edema and ARDS and all that they'll end up with in ICU. And then the phase 2 is, again, the biochemical mediators that cause a massive coagulation and DIC, and then the hemorrhagic phase due to consumptive coagulopathy and uterine atony. As we said, there's no marker of AFE. The diagnosis is one of exclusion. If you can't find any other cause contributing to the event, presence of these fetal cells is not to be diagnostic, but presence of cells in the bronchoalveolar lavage, however, may be supportive. In some recent studies been shown. So the non-specific tests, low hemoglobin, platelets and fibrinogen that our patient had, increased APTT and prothrombin, hypoxia and raised CO2 on ABG. A chest X-ray could show cardiomegaly and pulmonary edema. An ECG could show right heart strain and rhythm abnormalities. You could have VQ mismatch, and on echo, elevated right-sided pressures or left ventricular dysfunction down the track. But there have been some more specific tests that have been developed for diagnosis of AFE. Might be familiar with tryptase. It's not raised in all cases. Some cases are noted to be normal, but it's a bit more specific than the others on the left side. And also there's a recent test, that TKH2, which is a monoclonal antibody that reacts with the mucin in the meconium and amniotic fluid, that is noted to be more specific and rapid and non-invasive tests that could gain a bit more popularity in the diagnosis. Anishi and colleagues measured the tryptase in a few cases and reported a concentration on average of 67 nanogram per mil, where normal is 10 nanogram, but the others have done similar tests and found that it could be normal with low complement, though due to consumption. Transthoracic echo is useful. It's a sensitive tool to evaluate the cardiac function and intravascular volume status. And both transthoracic and TOE has been used by clinicians to manage AFE and also to diagnose it. So this we saw earlier on, evidence of right-sided high pressures and the bulging of the right atrium to the left side, and also somehow right ventricle. It's much larger than the left and bulging. And this one is in diastole. You can see severe tricuspid regurg. The mitral valve is closed, but the tricuspid is open and regurging up due to high pressures. Now, this could be an ECG that you might see if you get to that stage of doing an ECG. Can anyone tell me what they could see? So typical right-sided strain. That's right. So, like a pulmonary embolism, really, because in that situation you've got right-sided strain as well. So you could see S1, you could see deep Q in 3, and T-wave inversion. And sometimes you get V1 to V6 T-wave changes and depression and inversion as well. An X-ray that shows acute pulmonary edema, and we discussed why they could get that down the track. And management is basically supportive. It's based on resuscitation and early delivery and controlling airway. So if your patient's not tubing them because there's high risk of aspiration, and especially if they've got a fetus on board, knowing that you need to tilt the patient again if they're still pregnant and get that weight of the uterus off their circulation. And early delivery within 5 minutes. If your resuscitation and CPR is not working, you need to get the baby out. That will help baby and mum. And also then correcting coagulopathy. So you might need to use vasopressors and inotropes. They're generally needed for hypertension. Vasopressin is noted to be good because they say theoretically there's less chance of pulmonary vasoconstriction. Alan, I don't know whether you agree with that, vasopressin compared to the other inotropes as a vasopressor, but that was what I was reading in some of the studies. Then pulmonary hypertension, right heart failure can be managed with inhaled nitric oxide, milrinone and either phosphodiesterase inhibitors. And severe hypoxia and left ventricular failure could be treated with intra-aortic balloon pump, ECMO, cardiopulmonary bypass and left ventricular assist devices. Again, there have been cases that if they survived, that have survived going on ECMO and pulmonary bypass acutely. Management of coagulopathy, usual results is depletion of fibrinogen, low platelets, and you missing a lot of coagulation factors, especially factor 5, 7, 8, and 13. The fibrinolytic system is very active, and that's why your fibrinogens are consumed. And you've got low fibrinogen levels. So you give FFP for high APTT, you give cryo to correct your low fibrinogen, and you transfuse platelets as guided by the hematologist and how you're clinically looking. Now, recombinant factor 7 has been successfully used in many cases, but off-label, as you know, that there's no big double-blinded trials, Richard, and I don't know whether there'll ever be, and whether they could, ethically do that and ever do these trials. But in Australia and New Zealand Hemostasis Registry, it was developed to capture safety and efficacy of, and gather data of using this off-label for different cases, including obstetrics, hemorrhages, and there have been good results. I mean, there are some reports of increased coagulation and thrombosis, but as I said, we need more research in that area. Antifibrinolytics, that's something that they use, Sanjay and Jane, and that I was not familiar with and I would not have used, but aminocaproic acid and tranexamic acid have been used and they've been described in obstetrics hemorrhage and might be considered during amniotic fluid embolism. There's a trial called the WOMAN trial, Ward Maternal Antifibrinolytic trial, that's currently getting undertaken, which uses tranexamic acid for treatment of postpartum hemorrhage. And basically they give 1 gram, and then if you're still coagulopathic and bleeding clinically, they give another gram, and that's be interesting to know what the result of that trial is. And then, hysterectomy is required in about 20% of cases because either you're still bleeding and not able to control their coagulopathy because of bleeding, or you still have atonic uterus. And I think our case, and I'm still working on it, and hopefully I'll get to present it in CSM. It was unique in terms of that it was in a patient that was intubated at the time of event, so the reduction of end-tidal CO2 was quite apparent readily, and there was rapid ability to perform a transthoracic and also TOE that confirmed the presence of increased right ventricular pressures that's been described in these cases. And the most interesting aspect of this case was the fact that it happened so delayed, 90 minutes after delivery. And although there's potential for contamination of maternal blood by amniotic fluid during caesarean, it remains uncertain why the response was so delayed in this particular case. And for this reason, amniotic fluid embolism should be suspected in any pregnant patient who develops profound shock and hypoxia during or after delivery in recovery, for example. Treatment is supportive, and in our patient, coagulopathy resolved rapidly with recombinant factor 7A and antifibrinolytics, and it'll be interesting to see what the results of the trials are and use of these 2 factors. Any questions?
Thanks, Naga. Does anybody have any questions? Richard?
Just a minor point, tranexamic acid is now, the intravenous form is now approved for marketing in Australia, so you don't have to bother about filling out SAS forms for that or aminocaproic acid. So we're going to switch over to just stocking tranexamic acid instead of aminocaproic acid.
Excellent. Has anyone had a case of amniotic fluid embolism in this room?
I was an observer 10 years ago, but yeah, very similar case, intubated. Baby was delivered about 5, maybe 10 minutes later, the SATs started to drop away, increasing fractions of oxygen. SATs continued to drop away, and they became bradycardic, so it started. It was all very frightening. Yeah. In the end, they had supportive treatment followed by hysterectomy for coagulopathy. Spent about 6 days in ICU. Got better.
survived.
Do you know how many have been reported here?
In our hospital,
Yeah.
I'm not sure what the data says. Do you know, Ross?
Might be easy to find out.
I mean, it's generally a hard thing because of the difficulties in diagnosis and also reporting, because a lot of the maternal deaths don't get eventually, diagnosed with what the actual cause was. This is just worldwide and talking about. And also in research and when you gather data, you have to have strict criteria for diagnosis to exclude everything else. But
most, at least the serious ones, would be encoded
by
by
medical.
just a simple electronic search.
Mm.
Would be a nice city. Okay.
Given the immunological nature of it, what's the recurrence risk if you don't lose your...
It's shown actually that if you've had one episode, it doesn't, increase your risk of having another one. But as we saw with the risk factors being atopic, having eczema or asthma and these things puts you a bit more of susceptibility because of your immunological.
Well, sure. Yeah, I realise that. But only 30% do. So I just wonder whether you said there was an increased risk in male children, whether the sex of your subsequent children made a difference to your recurrence risk, if that was
Not
known.
that it's been reported, no.
It's probably a minor point. Was any mention in all of the stuff that you read made of the exact oxytocin management? Does bolus size or infusion rate or anything have any effect on this?
On the occurrence of amniotic fluid embolism.
Just via sort of uterine pain or anything like
Well, look, basically, having a turbulent labour, an induction of labour, is a known risk factor for this to happen. But there's no exact association with, you would think that, if you give more aggressive treatment and induction, you're at higher risk.
Okay. That's it. Thank you very much. There you go.
No worries.
Oh, sorry.